Hello, future doctors. Today we're going to tackle a huge topic in pathology, neoplasia. We're going to break it all down, piece by piece, starting from the very things that trigger cancer all the way to the lab tools we use to nail the diagnosis. Okay, let's dive in. So we're going to follow a really logical path today, pretty much how it works in the clinic. We'll start with the causes, carcinogens and those sneaky oncogenic microbes. Then we'll switch gears to detection, looking at how we use serum markers to get clues, and then how we lock in a diagnosis with IHC stains. Finally, we'll wrap it up with a summary and a key mechanism for resistance. All right, to really get a handle on cancer, you have to start right at the very beginning, with the things that actually cause it. So let's talk about these culprits, the carcinogens. What are they? And maybe more importantly, how do they do their dirty work? So, what is a carcinogen? Simply put, it's any agent, and that could be a chemical, it could be radiation, even a virus, that can directly cause cancer. The one thing they all have in common is that they damage our DNA. That genetic damage is what kicks off that uncontrolled cell growth that is the hallmark of cancer. This table right here, this is pure gold for your exams. These are some of the heavy hitters you absolutely have to know. And notice how specific they are. Aflatoxins from moldy grains, think liver cancer. Asbestos from old construction, bronchogenic carcinoma. And tobacco smoke, well, that one's a bad actor everywhere, hitting the lungs, bladder, pancreas, you name it. But here's where it gets really interesting. How do these things actually cause damage? You see, not all carcinogens work the same way. Some are kind of like sleeper agents. They need our own body to accidentally activate them. Others are just straight-up attackers from the get-go. Let's compare two perfect examples of this, aflatoxin and alkylating agents. Aflatoxin is the classic example of an indirect carcinogen. When you eat it, it's actually not that harmful. The problem starts when it gets to the liver. Our cytochrome P450 system, which is supposed to be detoxifying things, instead metabolically activates the aflatoxin. It turns it into the super reactive molecule that then goes on to damage the DNA in our liver cells. That's why it's so specific for the liver. Now on the flip side, you have alkylating agents. These guys are direct attackers. They don't need any activation. We actually use them as chemotherapy drugs. We give them systemically, and their job is to go around and directly damage the DNA of any rapidly dividing cell they find. It's what makes them great at killing cancer, but it's also why they have so many side effects, and can, ironically, cause other cancers down the line. That idea of widespread exposure from something like smoking leads us perfectly to our next big concept, field cancerization. This helps explain something we see in the clinic all the time. Why do some patients get multiple separate cancers in the same general area? Or why does a tumor come back even after we thought we got it all? The best way to think about it is like this. Imagine a farmer just scattering seeds all over a field. When a carcinogen, like tobacco smoke, washes over the inside of your mouth day after day, it doesn't just hit one cell. It damages a huge area, creating a whole field of precancerous cells. Any one of those cells is now just one step away from becoming a full-blown cancer. Okay, so it's not just chemicals and radiation we have to worry about. Some microbes, viruses and bacteria, can also be oncogenic. They're like cellular hijackers. They can sneak their own genetic material into our cells or make proteins that mess with our cell cycle, basically pushing our own cells towards becoming cancerous. And here are the big ones you just have to know. EBV, linked to Burkitt's lymphoma. Hepatitis B and C, huge drivers of hepatocellular carcinoma. Those high-risk HPV strains, 16 and 18, they're famous for causing cervical cancer. And the bacterium H. pylori, a major risk for stomach cancer. Seriously, commit these to memory. So we've talked about the causes. Now, how do we actually start looking for cancer in a patient? Well, one of the first things we can do is look for clues in the blood. And that brings us to the super important topic of serum tumor markers. Okay, listen up, because this is probably the most critical clinical point of the day. I cannot say this enough. Tumor markers are for monitoring, not for initial diagnosis. They're great for seeing if a treatment is working or for checking if a cancer has come back, but they are not for screening or diagnosis. Why? Because lots of benign things can make them go up. The gold standard, always and forever, is a tissue biopsy. Let's walk through a classic scenario you're definitely going to face. You get a patient's labs back, and you see a high alkaline phosphatase, or ALP. Your first thought should be, okay, where is this coming from? The two big culprits we worry about are the liver and bone. So, what's your next move? How do you figure it out? Here's the algorithm, your step-by-step plan. To figure out where that ALP is coming from, you need a more specific test. And the key one to order is GGT, or gamma-glutamyl transferase. GGT is much more specific to the liver. So if both ALP and GGT are high, you can be pretty sure the problem is in the liver. But if ALP is high and GGT is totally normal, you can rule out the liver and start investigating a bone issue. Let's run through a few other must-know markers. AFP is for liver and yolk sac tumors. HCG is the classic for choriocarcinoma. And for calcitonin, here's a great little mnemonic for you. Remember calcitonin because it's the marker for medullary thyroid carcinoma, which is a key part of the MEN 2A and 2B syndromes. See? Easy. So we've followed the clues in the blood, and now we've got our biopsy. We have the tissue. But sometimes you look under the microscope, and the cancer cells are just a mess. They're so weird looking, you can't even tell where they came from. To solve this mystery, pathologists have an amazing tool called immunohistochemistry, or IHC. The best way to think about IHC is like using molecular highlighters. We use special antibodies that will only stick to specific proteins found in certain cell types. It lets us figure out the cell's family tree. For example, cytokeratin is only in epithelial cells, so if a tumor lights up with a cytokeratin stain, you know it's a carcinoma. If it lights up with vimentin instead, you know you're looking at a sarcoma, which comes from mesenchymal tissue. Let's make this real. A neurosurgeon sends down a brain biopsy. The pathologist needs to know if the tumor came from the brain's supportive glial cells. So they'll use a GFAP stain. GFAP is a protein that's basically exclusive to glial cells. If the stain is positive, it confirms a glial origin, pointing right to a diagnosis like glioblastoma or astrocytoma. Okay, one more case. A dermatologist sends you a suspicious mole. To check if it's melanoma, a common go-to stain is S100. Now, why S100? Because it's a marker for cells that come from the neural crest. And if you remember your embryology, that's exactly where our pigment-producing melanocytes come from. A positive S100 stain is a huge clue that you're dealing with melanoma. All right, let's wrap this up. We're going to tie everything together and talk about one last super important idea. We spent all this time talking about how we find and identify cancer, but we also need to understand how cancer fights back against us. And this is a major way it does it: P-glycoprotein. Think of it like a tiny bouncer at the door of the cancer cell. It's a pump that uses the cell's energy to physically grab chemo drugs as soon as they enter and just throw them back out. This is a huge reason why a cancer that was responding really well to treatment can suddenly stop. The cells literally learn how to kick the drugs out. And to bring it all home, here's a super high-yield summary slide connecting the dots. See the logic here? Aflatoxin is a carcinogen that causes hepatocellular carcinoma. We can then track that cancer with the serum marker AFP. And if we had a mystery tumor and it's stained positive for cytokeratin, we'd know it's a carcinoma, a tumor of epithelial origin. It all fits together. So that leaves us with this final thought. Everything we've talked about today, from a specific carcinogen to a specific stain, it's way more than just facts for a test. This is the foundation of personalized medicine. Every single one of these molecular details is a potential target for a new, smarter drug. As you go forward, always think about how this basic science is changing the game for our patients. Thanks for joining me.